I would like to answer Raki's question at the end of my talk. So when I was asked to choose a topic for today's discussion, I thought that the topic should be useful for our PGs, PGs who are working in ILBS in the environment of hepatobiliary system. So I started interacting with them. I discussed the CT report. When we describe so many collaterals, do you read these collaterals? Do you require all these information for patient management? When we write a MR report and advise after the end of the report that advise ultrasound to rule out gallstones, what is your response to that? Then I discussed about imaging technologies. Rajiv has already discussed about AI generated softwares. We have the MRI, but a lot of AI enabled softwares are there. So it is depending upon the body composition, already the sequences are adjusted accordingly. The ultrasound image, the lesion is in the liver, but already machine adjusts accordingly and changes the parameters in such way that it is more detectable. And after imaging technology, I started discussing about the evolution of radiology. And finally, I zeroed the topic. So I asked few of the things, like who discovered X-ray? All replied Roentgen. Then I asked, what was the first X-ray? Some said the wedding ring of his wife, but actually it is the hand X-ray of his wife with wedding ring. Then I told them that the X-rays were discovered in 1895 and 100 years celebration was in 1995, and then President released the Indian stamp in the Vigyan Bhavan and we all were witness to that. Then I asked, what is intervention radiology? All were able to tell me it's a minimally invasive procedures performed under image guidance. So what image guidance? They said fluoroscopy, ultrasound, CT. So I told them that nowadays there are certain lesions, especially in breast conditions, which are detectable only on MR. So MR guided biopsies are available. Almost 10 years back, and a US biopsy company is providing the hardwares which are MR compatible. So intervention radiology, minimally invasive procedures are performed using image guidance, and the MR armamentarium has been added in this list. Then I asked how intervention radiology was born, how it grew in the area of hepatobiliary IRs, and what is the future of hepatobiliary interventions. So in next 20 minutes, I am going to discuss these 3 points with some take-home messages. So my topic of today's discussion is intervention radiology in India, especially hepatobiliary interventions, past, present, and future. Let's have the global picture of intervention radiology in this area, and for that I would like to refer to this article, The Birth, Early Years, and Future of Intervention Radiology, which was published in JVIR. This is a very high impact journal which is published from SIR, that is Society of Intervention Radiology USA. And these 3 authors, Joseph Roche, Frederick Keller, and Kaufman, these are stalwarts, and in next couple of slides I will show their contribution in hepatobiliary areas. So they mentioned that Daughter was the first person who in 1963 gave a lecture on angiographic catheters can become an important surgical instrument. And they have mentioned in this article that these were the persons who attended that conference. It was like a bombshell when he presented that angiographic catheter can replace some of the surgical techniques. So that was a time when all these diagnostic work was in infancy stage, and later on in a year he dilated this tight stenosis in an 82-year lady who refused to have an amputation, and after this angioplastic dilatation, at that time no balloon, nothing, stents, all these were not available, just like a urethral stricture, serial dilatation of this tight stenosis led to saving the amputation, and this lady walked away from the hospital, that is after this treatment. However, the term of intervention radiology was coined by Alexander Margulis, who is again a very renowned GI radiologist who wrote the Margulis abdominal radiology GI textbooks, which we all have read during our PG time. But the term of intervention radiology was coined in an editorial in AJR in 1967. So with this brief background, I will come to early highlights of 1960s to 1980s. So Daughter was very inspirational, as mentioned in this article, because he used to say that whenever there is any emergency, that emergency is the point when you can innovate these intervention radiology techniques. So whenever he used to dilate these things, whenever there is thrombosis, instead of giving these patients to surgeons, he used to try some new methods, and that's why the thrombolysis in 1972, catheter-directed thrombolysis, was started. In 1974, Grunzing first developed PVC balloon, PVC. This was a very basic balloon, and the first balloon dilatation of coronary artery was done way back in 1976. Then acute variceal bleeding. We all know that variceal bleeding mortality was very high, and during that time, this Roche, one of the co-author of this article, was very much worried about this. And in 1960, in a canine model, he did this TIPS, that is a tube between hepatic vein and portal vein, to reduce the portal pressure. So this idea was developed in Roche's mind way back in 1960. From 63 to 70, a lot of things were tried, like first of all, detection of GI bleeding on a conventional cut film angiography. Then infusion of vasopressin to reduce the portal pressure. Then infusion of epinephrine, infusion of low dose propranolol. All these were tried. Later on, subsequently, it was found that IV and through catheter is almost equal results. So something were done and then withdrawn. In 1970, Roche did the first demonstration of this bleeding duodenal ulcer, and later on treatment by autologous blood clot and surgical gel foam. So this was again a breakthrough in 1970, and in gastroenterology, an editorial was published with a sarcastic remark of turned off bleeders. It is available in archives. And after that, 70-80, flexible endoscopy developed, so entire scenario of the management changed. In 74, Lunderquist, the Lunderquist guide wire is still very popular today as well. He developed percutaneous approach of portal vein, and through this variceal embolization was done way back in 1974. And if we see today's time, all these procedures are done in a much refined way with the use of advanced hardwares. In 80s, nitinol stents were discovered, then wall stent, 85, and in 87, balloon expandable stents was developed by Palmer. And just next 1 year, a human clinical first TIPS was done with the help of this Palmer stent, balloon mounted. Today we all understand that balloon mounted stents have a good radial force, they stand for longer period of time. So patency, not only the procedure is done, but the patency is also important. It should work at least for few years. Now I come back to the intervention radiology in India. When we were asked to write intervention radiology in India, we were in a very infancy stage. We started our Indian Vascular Intervention Radiology Society from a small monthly meeting as a departmental club to a Indian society way back in 95. So I described some of the history of India, then job prospects and few other points which I am going to discuss in subsequently. But let me tell you, I am witness to my seniors, and some of the events are still as fresh in our memories as they have occurred yesterday. There was a time when pre-shaped catheters were not available, and like our garden pipes, all these rolls were available from 7 French, 8 French, 9 French, and we used to cut the length of the catheters, we used to make the shape of the catheter, we used to put the hub at the proximal end, we used to make these steel wires, steel coils, we used to keep these two things in a plastic bag, put some formalin tablets, then sterilize for 6 hours, then washing these catheters, and then doing angiography and interventions. The gas sterilization and other things were not available. Metallic needles, and this is 1978 transplant conventional cut film angiogram, which is showing the internal iliac attached to the donor renal artery. This is aortoarteritis, and showing irregular abdominal aorta. So all these things started from basic conventional angiography machine, no flicker-free monitors, good amount of radiation which we were getting, but we started from this. And what is today? We are having arterial sheath, we are having venous sheath, we are having crossover sheath, long sheath. We can puncture left side and go to the right side. We have all sort of catheters. We have all sort of embolizing materials, embospheres, PVA particles, coils, microcoils, MR compatible, platinum coils, and all these things are available. Not only that, all shape of catheters, C1, C2, Roberts, uterine, and all these 95 centimeter, 60 centimeter, 110, 120 centimeter catheters, balloon mounted catheters which can be fixed in hepatic artery, and then it can inject the material into the hepatic artery proper. Infusion catheters, micro catheters, Dormia basketing, loops, and various type of stents. So whenever there is any complication, we can remove all these coils and other things. If there is a broken piece of the catheter, all these things can be removed as well by intervention techniques. Now, as far as training is concerned, today all softwares are available, and we can train under ultrasound guidance on a virtual platform. But think the time when vendors used to bring big meat pieces, and we used to try biopsy guns on that meat pieces, but without any guidance, without ultrasound guidance, just checking the hardwares. And this was the phantom available, but very costly and not available in our country. So one of our PG student, he made a phantom with the use of gelatin, corn flour, and putting some olive seeds, putting some glove with water with red color solutions, and this was ready, costing 200. And with the help of this phantom, we organized workshops, and it worked for 2 days. And you can see this is working under ultrasound guidance. So ultrasound guidance, somebody is putting a needle and taking biopsy from this olive seed. Somebody is aspirating the fluid. Somebody is aspirating a thick fluid of pus consistency. This also worked under CT guidance. So we trained many younger radiologists on these phantom, homemade phantom. Now I come to, this phantom was actually, this Dr. Munir was awarded for this phantom, and this was published in AJR. Now if we talk of 90s, when we started chemoembolization, it was not a very popular technique, and even the liver clinics were not started even at AIMS. So we used to demonstrate these things, that this hepatocellular carcinoma can take supply from the inferior diaphragmatic, from the intercostal. There may be accessory replaced artery. So if we treat these cases by chemoembolization, it is very important that we should divide the dose, and we should supply, we should actually block all the vessels supplying the tumor. Like in this case, the tumor is getting supply from accessory or replaced artery. See example, the segment 4 lesion, which was extending to segment 5 as well, but getting very less supply from hepatic artery, but actually it was replaced right hepatic artery, which was arising from SMA. So if we want to treat the entire tumor, entire disease, then we have to identify these vessels and divide the dose and inject in this way, so that other lesions are also treated. These are some of the publications which are in early 90s. If we see today's time, 61 SCC published is not a very big number. It's a very small number, but it was start. And it was in 95, 96, 97, the 14 cases by RF ablation. So these techniques were started way back. But the major breakthrough was in 2000 to 2005, when International Atomic Energy Agency, that is IAEA, they started a radionuclide treatment project, and AIMS was selected in this project out of 10 countries, and we published this 93 cases by doing the radioembolization. If we see today's time, a tumor in the left lobe extending into left portal vein can be treated by chemoembolization. A tumor in the right lobe extending into right portal vein can be treated. But if the tumor, I'm talking of tumor thrombus, which is extending into main portal vein, then it is not a right case for chemoembolization, because after chemoembolization, we inject gel foam or PVA to make the ATP dependent pumps paralyze. So there will be necrosis. But in these cases, radionuclide treatment is possible. Nowadays, several other radionuclide material like yttrium and other things are available. And after that, we published few consensus documents in ICMR in different situations. Now I will come to the present time and would like to discuss some of the published articles which are useful for all of us. And one is this article published by Amar and Yashwant recently in Emergency Radiology, Role of Interventional Radiology in Vascular Emergencies in Cirrhotic Patients. The question which I asked a few of you, that when we describe so many collaterals on a CT report, is it useful? It is useful. And how it is useful? This has been article. So there may be acute bleeding. So all cases which could not be treated by endoscopic glue injection can sometimes be treated by interventional radiology. So Amar has very nicely developed this algorithm which is for acute bleeding, acute variceal bleeding when there is no hepatic encephalopathy, tips along with variceal embolization plus minus. When there is a gastrorenal shunt, then a salvage BRTO or PARTO. Then third is TIPS or BRTO, or in cases of ruptured SCC, few weeks back he presented a case of ruptured SCC where embolization is useful. Then iatrogenic causes, transjugular biopsy, percutaneous biopsy, or paracentesis or thoracocentesis. So depending upon the situation, we can choose the track and embolize material. So all these things are there. I will take few examples just to give you an overview of these techniques. So a TIPS has been done in this case using a 10 mm TIPS stent, but after this it has been noted that this gastric varices are there. We all know that gastric varices are high pressure system, and when it bleeds the mortality is very high. So through this TIPS he has placed a deployed vascular plug of 12 mm, and from the side a catheter, a glue, 30% glue has been injected through this afferent left gastric vein. In this article he has mentioned about the salvage TIPS, TIPS versus BRTO, and various other balloon occluded antegrade and retrograde, that is BRTO and BATO, and also some time saving procedures like plug assisted PARTO and coil assisted CARTO, and in these situations when these collaterals are not there, percutaneously approach of the portal vein or splenic vein, that is ATO, that is antegrade approaches have been described. See one more example. On a good CT portogram, gastric varices, bleeding, but there is a good sizable gastrorenal shunt, so a plug has been deployed, PARTO technique, and the sclerosant has been injected. So these procedures are useful in failed endoscopic treatment cases, and they are very useful. He has also discussed some certain points which are important. All of you to please learn that BRTO role in ruptured varix may not be very good because the glue will not stay in that. Then in certain situations we do BARTO and BRTO both combined. So it depends on the CT portogram, how many efferents, how many efferents are there, what is the filling vessel, what is the outgoing, and depending upon that, depending upon the size, depending upon the grading, we can decide which treatment is going to be more useful. Now regarding ruptured SCC, you can see there is a capsule rupture. So in these cases, this may be just infiltration of the tumor into duodenum in the hepatic flexure, or there may be after chemoembolization necrosis causing the bleed, and in these cases angiographic embolization is the aim. So immediate embolization by using PVA or by any other material is useful. Because of paucity of time, I will not go into details of all these things. Now see this case. This is the request form, a case of NCPF, underwent linorenal shunt way back in October 89, that is 35 years back. And Piyush came to me and said that we want to ligate this linorenal shunt. It is a very easy job for a surgeon, but patient developed clubbing and hepatopulmonary syndrome, and when we saw the patient, his tongue was totally blue. So surgery was not possible. So he said that do something interventionally. And during that time, we were not having much hardwares. So what we did, we placed a balloon, the longest size, the maximum diameter balloon at the site of shunt, and by the side of the this balloon catheter, we made a long steel coil, and 2-3 steel coils with some thrombogenic material were deployed, and this worked. And later on, this was published in AJR as a technical note. And at that time, BRTO, PARTO, all these things were in experimental stage, and plug was not discovered at all. We also treated GI bleed of ruptured hepatocellular carcinoma in a series, 5 cases. And as I said, embolizing material could be gel foam, could be PVA particles, because aim is just to block the bleeders, so that because the blood is not freely available, so aim is not to treat the patient but just to stop the bleeding. Now I will discuss this article, which is also published recently. Some of the techniques which are not described in earlier paper, and that is portal vein embolization in a future liver remnant hypertrophy. So as we know, if we do extended left or extended right hepatectomy, after major hepatectomy, because of less hepatic reserve, the surgery may fail. So in these cases, like in this case, after major right hepatectomy, this patient survived because the left lobe was initially not very hypertrophied, but after blocking the right portal vein, because of hepatotropic factors, the left lobe was enlarged. This is very useful in non-cirrhotic patients, and next 3 to 4 weeks time, and this was operated. Now direct intrahepatic portosystemic shunts, and that is DIPS, in this retrohepatic IVC and the portal vein, they can be connected with the help of a stent. So this is useful in Butt-Chiari syndrome. Then sometimes we do portal vein thrombolysis, that is required in certain situations. Then see this example, which I discussed with few residents who came for other cases. What would you like to do? This is the CT portogram, which is showing splenic vein thrombosis. There is a bleeding gastric varices, which is not amenable to endoscopic treatment. Left gastric vein as a efferent. There is no gastrorenal shunt. So in these cases, one can approach BATO, and that is through percutaneously approach the portal vein, inflated a balloon, demonstrated these varices, then sclerosant and lipiodol was injected, and the procedure is over. So gastric varices efferent could be left, posterior or short gastric. However, in splenic vein thrombosis, the situation may be reversed, and in this situation, this technique is useful. Now I will briefly touch this article in case of pancreatitis, post-operative. The bleeding aneurysm, the best approach is angiographic treatment. Go to the artery of aneurysm, block that. But sometimes it is not possible to reach. Demonstration is possible, but reaching is not possible. So in these situations, percutaneous treatment is useful. Sometimes we take the help of endoscopy as well. See few examples. This is an aneurysm, and we have packed this with the sac packing, very easy procedure. But if the aneurysm is from the gastroduodenal artery, it is very important that you should cover proximal and the distal, that is front and the back door. If you block only the proximal portion, it will refill from the back door and the procedure will be useless. So you have to block the front door and back door, which is known as sandwich technique. Now sometimes the aneurysm is seen, but the aneurysm is from the jejunal artery, post-operative, or a small ileal artery. You are not able to reach, you are able to reach the superior mesenteric artery, but not able to reach the artery of the aneurysm. So in these situations, nowadays Xenex persons are so good that under ultrasound guidance, they can place a long needle and can hit the aneurysm and can inject thrombin or glue. So don't leave these cases, and one can try ultrasound guidance, long needle, and inject glue or thrombin. Now this is the case of pancreatitis. Aneurysm is there, very well seen on CT, but not approachable through angiographic approach. So endoscopically, a needle has been placed and glue was injected with the help of endoscopy. Now I know trauma patients are not coming here, but tomorrow you may go to a center where trauma patients are there, and in road traffic accidents, solid organ injuries, aneurysm lacerations, the angiographic treatment is the very good option. Like in this case, the aneurysm is there, and this is the artery of the aneurysm. One can approach this, can block this with coil, but it is important to identify the anatomy before proceeding for intervention. I always remind that the anatomy and the basic thing is very important. If you notice, the artery is posterior portal vein. So if it is posterior portal vein, it is arising from superior mesenteric artery, and you need a microcatheter, you need a different hardware. Otherwise, after 2 hours exercise, the entire exercise will be futile, because you will not be able to reach the aneurysm, artery of the aneurysm, if you are not having a proper hardware. Splenic artery aneurysm, embolized by steel coil. Now, road traffic accidents are not limited to only one organ. This is a case where there is one aneurysm in the neck, one aneurysm in the thorax, and it is leaking in the brachial artery. So, fortunately, distal to carotid and vertebral, so a covered stent has been deployed and both aneurysms are sealed off. This is 2-year follow-up CT. So, a small procedure but big advantage. Now, many of us might be knowing Dr. Chatterjee. He is a very renowned and very dedicated esophagus surgeon, and I am very fortunate to work with him for almost 3 decades. So, this is a case of C esophagus. One can see this is a C esophagus and this is the leakage after radiotherapy to pleural cavity. And by endoscopy, placing a stent is a very easy job, using a 70 centimeter length with valve or without valve, a good esophagus stent covering and this entire thing. But aim was not to just cover but to seal this fistulous communication. So, we placed this Z stent and placed a biggest size balloon which is available mitral valvotomy and inflated this balloon inside this stent for 30 minutes, and after this, when we deflated, this was totally sealed, this procedure sealed the communication, and this patient who was coughing for last 3-4 days stopped coughing after this procedure. So, one more example, Boerhaave's disease. Surgery is the only option, surgery is the best option, and surgery should be done, but at times surgery is not possible. So, in this case, because of the poor condition of the patient, we have placed a stent, covered this rent, and definitive surgery was done later on. So, these are some of the cases where intervention radiology can be very useful. So, with this guidance, we published 30 odd cases of these type of complications after radiotherapy, after so many other treatment therapies, and did these and helped these patients. Now, in last 2.5 months in this ILBS, I have noted cavities, lung cavities, bleeding hemoptysis, and also CT with collapsed vertebra because of longevity. And in all these cases, we can do vertebroplasty. Why I am showing this? Because everything is available here. So, vertebroplasty is one such procedure where we can inject cement in the vertebra and prevent the further collapse of the vertebra, and this can be useful because patient can walk, can do his daily works, whatever disease he is having, whatever life he is having, that is there, but at least he can do his basic needs and can walk. So, this is a procedure, and if you see the corporate hospital websites, everywhere it is mentioned that the minimal invasive methods, these vertebroplasty, kyphoplasty, and vesselplasty, which is done by orthopedic surgeons and by intervention radiologists. So, this is the needle which has been placed through the pedicle by hammering and placing this. It is placed in the osteoporotic vertebra, but be careful that osteoporotic vertebra are just like a cheese ball. So, it is very easy to place needle, but if you do hammering, then it can cross the vertebra and can go into aorta and IVC, two major structures. So, it is placed in the vertebral body. Then we take 3D rotation. We have 3D rotation here as well in most of the machines. And once the needles are in proper place, we make a cement which is in two forms, powder and liquid. When we mix these two, it polymerizes and then it can be injected. So, once the needles are at a proper place, we decide the amount. We make cement in the angio room. This is powder and another is liquid. When we mix, we have only a fixed time of 3 to 5 minutes. In this, we have to prepare, we have to inject, we have to check, and we have to remove the needle, and this is a daycare type of procedure. So, you can see this cement is now ready to inject. So, we can attach 1 ml syringes, or we can, and there are some injecting devices as well. So, this is 1 ml syringe, and we can use some injectable devices as well. So, just one more minute. So, this is by 1 ml syringe, easy method. Other injection devices are available. So, by rotation of these things, a fixed amount it can be injected, and not only the amount, you can see the hands are off radiation, so you can save radiation, although the machines are now very good and radiation is not an important issue. Now, with this, I have reached to my final slides, and This is the SIR president. During my presidency of ISVIR, he came and we organized a workshop. Nowadays, it's a common affair. Now it is 15 years old story. So every year there are Chinese society, Singapore society, European society, New Zealand society. They are coming here, they are organizing workshops, they are organizing cadaver workshop. I'm sure now Amar is president-elect, and in future, a lot of these workshops are possible here as well. So in these we can train, we can exchange views, and these are the machines of today. They earlier when we used to do, there were no flicker-free monitor, but nowadays these fusion and hybrid labs are here, and these are all not international pictures. These labs are available in our country. This is lab present in PGI Chandigarh. I have done few cases there as well. So after chemoembolization, a perfusion imaging is possible. So we can decide how much tumor is left out and how much amount in the same sitting can be used. Now I am coming to the final, and that is today's time. Past, present is over. So present time, job prospects have increased. We have convinced National Board and also MCI and now NMC and started DM courses in several institutions. Shortly it will be started here as well. Subspecialty recognition is already there. This is a photograph of Roche. In 1960 he did experimental tips, and this is 15 years back. I got an opportunity to go in a fellowship, and age is just a number for him. Then these two hands are holding a needle and third hand is taking biopsy. So when I show this slide, it's very important for all of us. It's a teamwork. Two hands can do wonders if it is supported by third hand. So it's a teamwork by all of us. And these are my last day photographs with my students. This is Madhusudan. He is very good in diagnostic and intervention, and some of the cases putting a long needle percutaneously to a small aneurysm, putting a long needle from retrohepatic IVC to portal vein in one go. Such a long needle is not an easy job. So Dr. Sneh Bhargav, she was the director and also head of department of AIMS. She used to say, whenever she was coming to department, she used to say, change the name of radio diagnosis, change it to radio diagnosis and intervention radiology. Together we grow. And when we changed the name, she was very happy, and she said that now the department will flourish to new heights. Thank you very much for your kind attention. Thanks.